introduction.
I've come to the floor today to talk about the amendment that Senator McConnell brought forward in terms of repealing the health care bill. And I'm probably going to approach this different than a lot of my colleagues have. I don't doubt that the intent of what was passed a year ago, last December, was well-intentioned with the thought of really solving healthcare problems in this country. My experience is 25 years as a physician, and the 10 years before that as a manufacturer in the medical device field gives me a little bit different take on what the consequences are associated with this bill. And during that hearty debate that we all had, I made some claims that people doubted in this chamber, which have become absolutely apparent and true. Costs are going through the roof faster than what we thought. Portions of people can't tolerate the plans, so we're giving them exemptions because it won't work in the business model to keep people covered. But most importantly, what is getting ready to happen is really what happens between a patient and their access and their care and their provider. And as well-meaning as the bill was, the destruction of that aspect of health care will cause us to rue the day that we've put into motion what we're putting into motion. And let me explain it. Most of the doctors in this country became very interested in this health care bill, and rightly so. They're the ones that are going to be impacted along with their patients because they're the ones delivering the care. And when you poll those doctors, what do you find? Now that they actually know what this bill is going to do. Well, some pretty significant statistics have been come out, one by Thomson Reuters, where 2/3 of the doctors in this country absolutely believe that the care of their patients is going to suffer as a consequence of this legislation. Now think for a minute, if you're an individual needing to access care, and we're at 2014, 2015, and the Advisory Payment Board of Medicare is intact, and we also know what the Medicare trustees have said about that when this is fully impacted and the payment under Medicare, this is a very important point, the payment under Medicare will be less than the reimbursement for Medicaid, less than the reimbursement for Medicaid. So all of a sudden, what was your family physician or who was your surgeon is no longer there. So you see, this bill really is about whether you can walk in and have the attention and care of somebody dedicated to you who has your best interests at heart in terms of your health. And what we're moving to is somebody who's going to have their best interest of survival at heart and your interest second. And that's the real tragedy of what's happening with this bill and the implementation of it. Not only are we going to have payments reduced on Medicare, that's the only way the bill works, by the way. It's the only way we can ever get out of the jam until we address really fixing Medicare. But 55% of the specialists in this country today won't see Medicaid patients at the reimbursement rate that we have, and we're going to have a reimbursement rate for Medicare lower than Medicaid. Let me give you another example. What we know on Medicaid is that if you have no insurance and go to an emergency room with a significant illness, and you have Medicaid and go to the emergency room with the same illness, the outcome for you with no insurance is better than the outcome with you with Medicaid. And that's been repeated in 4 different studies now. And we're putting 18 million people into a system that are not going to have access to the best doctors because the payment is so low that there's a loss every time you see a patient. So describe to yourself for a minute, what happens to the mother who has 3 young children and has their 4-year-old all of a sudden sick with a fever, and there's no primary care doctor available under the 18 million new people that are going into Medicaid, and this child, it doesn't get seen for 72 hours. The mother thinks, well, I'll wait the fever out. I don't have a doctor I can call. I'll wait the fever out. And when the child gets to the emergency room, because there wasn't a primary care doctor for that Medicaid patient to call, what do they find? They find a 4-year-old, not with otitis media any longer, but with the early stages of meningitis. And what was a simple, treatable disease, because access, even though guaranteed, was denied because there's not the available resources to care for that child, the child ends up with a very complicated hospital stay and potentially the loss of hearing or brain damage. Those are the real consequences of what we're talking about as we put 18 million people into a Medicaid system. We've had several senators today talk about the cost and the gimmicks. I'm not going to do that. But I want to talk about the real issues. And the one place that we failed in healthcare is we didn't fix the real problem. The real problem is everybody's healthcare costs too much. And we didn't ask the right question. How do you drive costs down? And even when you go through all the numbers that have been given by CBO, Medicare trustees, Medicaid trustees, and outside studies, what we know is, what we didn't do is we didn't drive any costs down. In fact, in short term, we've actually driven costs up. So how do we do that? The way we do that is put some responsibility on both the physician and the purchaser of health care for the costs. And it's human nature. You know, if I gave you an insurance card for your groceries, and once your deductible was met, all you had to pay was 20% of that from then on out, your diet would significantly improve in terms of the quality and price of the products that you buy. That's all our human nature. And what we fail to do is to address the real cost drivers. And that cost driver is there's no connection with my purchasing of health care with actual payment of health care. Now, how do we know if we connect it, it works? Go to any place in the country that has Amish folks. They don't have health insurance. None of them. They don't buy health insurance. But what do? They are grand consumers and very discretionary consumers of health care, because they come forward and they want to know what they're getting and what it costs before they buy it. Every time. I've delivered over 500 Amish babies, and there was not one time that I wasn't asked at the time that the patient came to see me, what's the price for this? Will you take a cash payment up front to where I can buy it for cheaper? Are there some other places where I can get the test done? Every test that I would order, I would be questioned on whether or not they absolutely needed to have the test. They were discretionary purchasers and very sharp in their discretion on how they bought health care. So consequently, their cost for the same thing was 40% less than somebody who walked in with insurance. And so we've totally missed this connection of market forces allocating scarce resources by making discerning consumers out of the purchasers of health care. We've gone exactly the other way. We've taken people who are 133% of poverty and said, you're going into Medicaid. And by the way, you can't buy a private insurance even if you want to. You have to be in Medicaid, a far substandard health care system. All the studies show the outcomes are poor. even after you equate for social disparities. We're going to put $18 million into that program, and we're going to have a shortage of over 100,000 primary care doctors in this country in the next 10 years. So who's going to see them? Now, let me give you another example. Happened this weekend. A patient, 90 years of age, severely bent over from kyphoscoliosis, bad aging and kyphoscoliosis, is running a fever and can't breathe well. She goes to the ER. She had seen a physician on Friday. She had a chest x-ray, no pneumonia showed. She goes to the ER that night. She got a pulse ox of 81%, normal is 93, 94%. They put her on oxygen, change her antibiotics, and send her home. Well, what happened? Had we not interceded, I personally as a physician make a call to another physician, she'd be dead by now. Because what she had was a full-blown raging pneumonia and restrictive lung disease, but she was sent home from the ER. Because a physician, not a doctor, a physician did not see her. So consequently, she goes back to the ER the same night and is admitted to the hospital. They take a chest x-ray and all of a sudden they see this full-blown pneumonia. She had all the symptoms. But the person seeing her ER didn't have the experience to make the judgment. So is that really what we want? We want substandard care so somebody can go home and die versus coming to the hospital. And today, she's 200% better. She's eating. Her pulse ox now on room air is 91%. We've actually saved her life because a real physician put hands on a patient and made the right diagnosis. But we're going to put people into a system where that doesn't happen because we're going to use physician extenders. And that doesn't mean they're bad. They just don't have the same experience. And people die when they don't have the same experience. But we're going to inflate the utilization of less than a physician to care for the vast majority of these people that are going to go into Medicaid. These are real examples of what the consequences are of what we've done. As I started out, I said, I don't doubt the intent of my colleagues in terms of what they were trying to get to. But the biggest disease Washington has is fixing the wrong problem. We have expanded under this health care bill access. But access doesn't mean you're going to get care. And when you add 18 million people to the Medicaid rolls, let alone what's going to happen to the states, ultimately, with a cost on the maintenance of effort where they have a Medicaid now and we're going to go to 133%, what you've done is put the states in a pinch. And they're in a pinch already. And my question to my colleagues is, where are the things that drive the cost down? Where's the discerning consumerism that allocates scarce resources in the most effective way in this bill? It's not there. Nowhere. Is it there? Now, what is there? What is there is a tremendous amount of new taxes. $52 billion over 10 years on employers who fail to comply with the insurance mandate. 40% excise tax on high-cost health plans, $32 billion. Ban on purchase of over-the-counter drugs from somebody's health savings account, $5 billion. Increased Medicare tax on wages on small business of 0.9%, and a 3.8% surtax on investment income, that's $210 billion. Increase from 7.5% to 10% of income, the threshold after which you can make a medical deduction. $2,500 annual cap on your flexible spending account contributions, and I'll go through this and through this. The point is we're increasing by $2.6 trillion after this thing's fully in play, spending on health care. And it's been discussed on floor, the gimmickry in terms of the counting, the problems associated with that. The other things that are there One of the things that's there that concerns me as a physician, getting back to talking about patients, is cost comparative effectiveness. It was really cheap to send that 90-year-old person home. There was an ER visit, a little bit of oxygen, a change in antibiotics. That was really cheap. Comparative effectiveness would have said, oh, that's okay. Except she would have been dead in 24 hours. So every physician who is maintaining their license or their specialty certification studies comparative effectiveness every day. They read it in the journals. They do it to get recertified. They know the comparative effectiveness. What they don't know is what we're going to mandate what they will do. What is the cheapest? Not what is the best, what is the cheapest? Well, I would tell you, if you look at heart disease in our country, if you look at cancer cure rates in our country, if you look at recovery rates from massively serious illnesses in our country, from both trauma and otherwise, what you'll see is the highest rate in the world of recovery. We have the highest 5-year survival rate on almost every cancer, by 20 or 30% over every other system in the world. Do we really want to put that away? Well, in 2003, I was diagnosed with colon cancer. Had metastatic colon cancer. I'm so thankful for the healthcare system that we had, that generated new devices, that incentivized great care. And after a major surgery, where half of my colon was taken out and a radical lymphadenectomy was carried out, and 6 months of chemotherapy, I stand before you today, 7 years after that, alive. And I want to tell you, had I been in England or Canada, my cure rate would have been about 35%. You know what it is in this country for somebody with metastatic colon cancer? It's nearly 70%. Now, what created that? What gave us the technology to do that? Is because we looked at the best clinical effectiveness, not the best price. We said, how do we best and most effectively get an outcome of cure? This bill goes the other way. This bill is going to mandate from Washington what your doctor can do for you. It's also going to mandate from Washington what price your doctor will be paid. And there's no question that according to the trustees for Medicare, for us to maintain what has been put in this bill, Medicare reimbursement rates will fall below Medicaid rates. So do we really want that to happen? And I would tell you, for those in my condition, those people who are diagnosed today with colon cancer, you don't want that to happen. Now, how do we get the cost down? There's no question there's tons of waste in our healthcare field. And we've not attacked in the way we should attack. And I can speak as a practicing physician that I wasted money caring for people because I didn't concentrate on that individual because that individual wasn't paying the bill. Some nebulous insurance company was paying the bill. Some government program was paying the bill. But when somebody like an Amish patient looks you in the face and you know that what you spend of their hard-earned money is going to come directly out of their pocket, all of a sudden the other obligation of a physician jumps up. How do I do this in the most efficient and effective way that still gives the best outcome? And we've totally missed that. The most personal of all interchanges between humans, besides those of in a family, are between patients and their physicians. And we're going to interrupt that. We're going to undermine it. And we're going to undermine it because somebody from Washington is going to be looking. Did you do it the way we said to do it, doctor? Now, what is the doctor's oath? Is it to do what Medicare says? Or is it to do what's in the best interest of the patient? And that's the rub. That's where we're going with this program. And so what we're going to have is, first of all, we're going to have tens of thousands of physicians retire over age 55. Our best, most experienced physicians, they're leaving. They're not going to play this game. And then we're going to give physician extenders the role as primary care. Very good in what their limited knowledge will give them, but not anywhere comparison to 8 years of full medical training, including residency. They have 2 years. 2 years. And then we're going to treat all those. What do you think the cost of that's going to be in terms of lost lives, in terms of delayed diagnosis? Delayed care is denied care. What good is it if I have Medicaid and I can't see a doctor? So the problems are very real with this bill. And I don't say that as a fiscal hawk. I want to fix health care, and I want to drive the cost down. And we can drive the cost down $300 or $400 billion a year. Thomson Reuters did a study. I talked about it in our debate last year. The fact is we know that over $580 billion a year is blown in health care. That's enough to cut everybody's health care costs 20% in this country. But we didn't address any of those issues. Not one of the issues that Thomson Reuters has brought up that said, here's what's wrong, here's why health care is more expensive. We didn't address those in the health care bill that was passed. And yet we wonder why we're out here wanting to change this bill. It's not so we can say you did it wrong, ha, ha, ha. It's because we really care like you do that we got to fix the real problem. And this bill didn't fix the real problem. And so I hope my colleagues will take in the spirit that it's intended that we don't believe that we've done anything except expand coverage under a very broken system that's highly inefficient, that tells people they're going to have care but they're not going to have care, and those that have a doctor are going to be told by the federal government what care they're going to have. It's exactly the opposite of what we should have done, and we did it in haste. We know there's 1,600 new sets of rules coming, of which about 100 are through. We got another 1,500 to go. And CBO says that that's $100 billion in costs just to implement all this, which was never even considered in the cost of this bill. And that doesn't consider the cost of complying with all the new rules and regulations. So my time is up. I'll be back to talk on this again. But my hope is that now we have 3 physicians in the Senate. We've all seen the same thing. I'm a primary care OB, one's an ophthalmologist, and one's an orthopedist. We pretty well got it covered. And what we've done is not going to work. We're going to be sorry we did it, but you know who's going to be the most unfortunate receivers of this? Is the people who think they have care who don't. The people who get seen by less than qualified individuals for the care that they need, and we're going to pay twice what it should cost for it. I yield the floor.
Mr. President.
The senator from Alabama.
Mr. President, I ask unanimous consent that I may proceed in as